So, a very good evening to all of you.
Thanks, sir.
I wish that all of you mute yourself, except Dr. Rakesh Gupta ji. So, today, again, we are bringing to you one of the very important topics that is relevant to a postgraduate. Usually, what a postgraduate is given first, tonsil, then adenoid, then septum. So, I'm trying to cover one by one. In between, we'll bring some good surgeries like parotid, all this thyroid and all. So today, we are doing it under the banner of Indian Federation of Otolaryngology Head and Neck Surgery. And we have two people here. One is me who has founded this. And second is my brother, Dr. Rakesh Gupta sir. So he is forming the whole association. And I wish that he talks a few words about the association, how it's going to run, how academic it's going to be. And we are going to send an email to all the ENT surgeons across the globe. And this is going to be a very, very, very interesting forum. You're going to see. We'll bring all the academicians. Without much ado, over to Dr. Rakesh Gupta ji from Chhattisgarh.
Hello, Janki, and all who has joined here. My wish and best wishes of the new year and to all your family. On the proposal of some friends like Dr. Janakiram, we have discussed the formation of the trust in the name of Indian Federation of Otorhinolaryngology with my lawyers and have submitted few documents required by him. I have discussed the membership also with him and formation of state and city branches as well, including the metros. And the provision of making membership for the foreign nationals will also be there so that they can join as life member. All of them will join as life member, one time life membership, and we will devise a yearly plan for the academic activities across the India. And we'll invite good surgeons, good teachers, including the medical college teachers who are working in other hospitals. And we'll incorporate other subspecialties as well, like pediatric ENT and head and neck surgery and other specialties which are touching the ENT subject as well. And I think the once we submit the documents to lawyers who are doing the trust work also, after submitting the document, the registrar will inquire regarding the other documents, and as soon as the trust formation is done, we'll open the uh, bank account with the PAN card, and then you will receive the membership proposals. And I think it will take around 30 to 45 days. And all suggestions regarding the academic activity in this forum are most welcome. We'll try to incorporate each and everybody who wants to teach, the juniors and all of us, because teaching is continuous process and learning is continuous process throughout your life.
So thank you very much, Dr. Rakesh Gupta ji, for those nice words. It's a very heartening, move to start Indian Federation of Otolaryngology. Dr. Sarika Verma is here. Would you like to say a few words, Dr. Sarika? Can unmute.
Many congratulations to both of you. And as you know, we've been friends for, I think, more than 10, 15 years. I'm very delighted that you have taken this initiative. And I hope that we can go beyond the politics that is affecting a lot of our ENT associations and do pure academics, and especially for the younger people who need to see that is, I mean, we already have politics in politics. We should have academics in ENT and associations. And I look forward to working with both of you.
So thank you very much, Dr. Sarika, and thank you very much, Dr. Rakesh ji. Without much ado, we will, because many people are waiting for the topic, I think we will start with the topic. So over to this topic, very, very interesting topic. And this is very useful for the postgraduates. I have now received several messages from all over the globe, not only India, from Syria, from Uzbekistan. There are some Fozicon is from Uzbekistan. Many people are watching it and they say it's very useful. Today's topic is going to be septal correction. So let us share the screen without much ado. Okay, here we are. I hope you can see the screen.
Yes, sir.
How do I? You don't know. Okay. So, so the first slide I want to show here is septal correction difficult or easy? Basically, it's in my opinion, it's a difficult case. It's not easy. Many people think septal correction is easy, and it is difficult. The reason is because you do it with an endoscope, and you need hand-eye coordination. And the minute you use a 4 endoscope inside that small narrow cavity of the septum between the two flaps and put a suction, it'll get formed. So this is the difficulty. And also you'll have to see the screen. If it is an anterior deviation, some people say I use headlight with endoscope, just headlight, so many versions. Today we are going to concentrate on purely endoscopic septal correction. So to me, it's a piece of art. It's an art. It's like chiseling an art. So you see it on the big screen. Don't see it in a phone. You may not relish it, this video particularly. Now let us see. Let's see a septal correction in a hypertensive with an acute spur. So before we start this topic, we need some historical perspectives. I got a little incentive from my son, Dr. Satya, who made a C technique. So I did a lot of AI work. I thank my AI team for doing it. The challenge in this surgery is not to tear the flap on both sides. Why do I say this? Why do I say that tearing? Some people say, what is there if you tear a flap? In fact, you will not believe Professor Stamberger, if there's a big spur, he'll make a horizontal incision over the spur. The reason why I say that you should not make a tear is because, see, for example, I am a skull-based surgeon and I need a nasoseptal flap, Hadad flap. And if I need a Hadad flap, I can't have a tear in between. So if you practice this technique of preserving the flap on both sides, you will become a fantastic skull-based surgeon. So this is the idea with which I keep telling my residents, try not to tear the flap on both sides. Of course, after you do the surgery, you can make a small cut. The common saying is, oh, we can tear the flap on one side. But the problem is if you tear it on both sides, believe me, you can see a lot. Today in my OPD alone, I saw 3 septal perforations, septoplasty done elsewhere. So this is the problem. Now, let us all, what I say is try not to tear the flap, even if you have an acute deviation, is what I keep telling. Now, this is a big salute to this great gentleman. You know who he is? He is Professor Cottle. And you see what he says?
Hello, how are you?
So this is Professor Cottle saying hello to us. Of course, these are all AI images. So now, you after Cottle, in fact, in an exam, many people ask, you tell me what are all the things in which Cottle comes. Cottle's test, Cottle's elevator, Cottle's maneuver, all that. So this is a very important sign. So if you ask the patient to move his cheek outwards, and if he can breathe nicely, then it is called the Cottle's maneuver. And if he breathes nicely, that means there is definitely a septal See how clearly. And this is how you do it. You can do it in your OPD. We also have what is called a Cottel's line, which joins the anterior nasal spine with the frontal spine there. So previously we used to say
video, sir.
no video.
Stop.
You didn't get video till now?
There is no video, no video.
From the beginning?
Yes, from beginning, no
Yes,
video.
sir.
My God.
Sir, no AI video, sir. Only the AI video. Your video is
No,
good.
now
we
the
have
slides
video.
have started.
Yes, now we have a video. Now we have a video.
Can you see it now? Can you see the video now, please?
Yes, sir.
Yes, sir.
Okay.
Yes, sir.
So let's see a septal correction in a hypertensive individual with an acute spur. I keep telling, don't tear the flap, because you have to become a skull-based surgeon where you can harvest a adult flap without tearing, even if it's a very acute spur. Now, this is Professor Cottle.
Hello, how are you?
Saying hello to all of you. So this is the Cottle's maneuver, and this is very often asked in the exam. So tell me, what is Cottle's test and all this? This is pulling the cheek laterally. I hope you can see the video, please.
Yes, sir.
Okay, this is the Cottle's line. Previously, during septal surgery, we used to say anterior to this spine, you have to do septoplasty, posterior to the spine, you do SMR, all that. All that is gone now. Okay, if an examiner is asking about it, he is 2 decades behind. Now we call it endoscopic septal correction. That's all. It is called endoscopic septal correction. These are all pre-endoscopic days in which all these lines were described. So you can see that this is the publication which we made. I really thank Dr. Uday Chanukya, who made this. He is from Kakinada. I will share this article in all the groups. And this is a very, very, very nice technique of doing a septal correction. And it's called modified endoscopic septoplasty, a novel technique. It has been published, and you can see that we have. Please don't talk, because I cannot unmute you. Okay, that's the article. And then you can see here, this is again another AI video.
Truly appreciate your dedication and hard work. Thank you, sir. I'm grateful for your guidance.
So that is Cottle talking to me, that we have modified his technique. We used to say it's called Cottle's maxilla premaxilla technique, but it's no longer called maxilla premaxilla technique. Now I'm going to depict it in the form of pictures. This is the pictures I have drawn. Imagine this is the septum. The septum is deviated towards the right side. It's deviated towards the right. This is the pic one. So I'm going to show the same thing in the endoscope. Let us see. So that is the deviation of septum towards the right side. Now there is another spur here. You can see there is a spur. This is septal deviation. Now previously we used to say septoplasty, make it concave, convex. Please understand, all those concepts are gone. If you read my publication, you can clearly see wherever the anterior deviation is, you have to make the incision on the side of the deviation. Very, very clear. You have to make the incision on the side. So first you put an endoscope. You can do even a anterior dislocation with an endoscope. You don't need a headlight if there is a anterior deviation. Please understand, if you are able to move your endoscope, manipulate your endoscope, you can do a completely pure endoscopic approach. You have to learn this, please. Now, this is the deviation. So what is the first step? The first step is infiltration. See where I infiltrate. Carefully see where I infiltrate. I do not infiltrate. I have seen many people infiltrate here, 10 infiltrations they'll make. So what will happen if you infiltrate here, it will come through this. If you infiltrate here, it will come through this. So it is a single plane. Please understand, the subperitoneal plane is a single plane. So you just need one infiltration, and that too inferiorly, and that too on the skin. This is the skin, the mucosa. This is the mucocutaneous junction. So on the skin, you make it inferiorly. That is the first infiltration. And what do you use in this? You use saline, normal saline. See, I'm now making the incision. So this is saline infiltration. And where do I make it? This is the pictorial representation. You make it on the skin, most anterior part, and you make it inferiorly. Why you should not make it here? Because when you use the endoscope here, this will get fogged. So you don't want to make that infiltration there. So, and another thing is, don't make it at too many points. You don't need to make it at two. So see here, if you properly infiltrate with saline, it will blanch. This is how it will blanch. Same way, this is the buckling on the other side. So there can be some strands which are attached to this. So we need this flap is like platinum, diamond. Now it is gold and silver. You see the rates going up. Huh? So you have to protect this flap. How do you protect this flap? You infiltrate here and you see that this one comes out. So see here how I infiltrate. So this is hydrodissection. This is called hydrodissection. So I'm going to use my endoscope and I put my endoscope inside and then I use my needle. You can use a 26 gauge needle or a 24 gauge needle and see how I infiltrate now. See how it's coming out. This should be the aim of your infiltration. You should not waste that saline. See, it'll go back till back. It'll see here. I'm going up and down. So that is because I want to see that has got elevated. So very, very important, my dear friends. So what is the step 3? So I divide any surgery into steps. And this is the step 3, picture 3. You make the incision. Now there is a trick in making the incision. Very, very important. See, I've seen even the super demonstrators making a foolish thing by making the incision on the mucosa. You have to make the incision on the skin. Why? Why you should make the incision on the skin? Because if you make it on the mucosa and you just retract it or you keep cottles and elevate, you will have a tear here. You will have a tear here. So if you don't want to have a tear in this septum, you should have a thick skin. So that is why I make that. Suppose you have a anterior dislocation, same area I'll create a pocket here. That's it. I will show you in a different this one. So make the incision on the skin. You see, you can see the difference. No, this is skin, squamous epithelium. This is not squamous epithelium, cuboidal epithelium, respiratory epithelium. So ciliated columnar. Now you can see here, that is the incision which I make. You make it with a 15 blade and you see what is happening here. You should have a staff, good staff, who will suck the blood. So please don't infiltrate xylocaine with adrenaline. Why? I've heard about several deaths due to infiltration of xylocaine with adrenaline. Why? Because this is extremely vascular and you infiltrate, there are small capillaries and the adrenaline or xylocaine will go directly into capillaries. Patient will have a cardiac arrest. Please understand. So I have heard in at least 3 or 4 cases death due to xylocaine infiltration. So don't do that. Now, once you make the incision, you see here how I'm making it. You should make it. See, many people make a very, very small incision. See, they make an incision from here to here. No, from right above till the floor, make a one stretch incision. This is very, 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 very important, my dear friends. This incision is very important. Make it on a skin. Now, what is the step 4? Step 4. See here, picture 4. Now, what you do, this is a deviated part, and you have a spur here. I'm showing this picture. I elevate anteriorly. Don't elevate too much. Just a little you elevate. See, I'm going to show you that. So this is the next step. See, I'm teaching like a child will teach. So I'm just elevating just a little bit. Then I am making a small slice. I'm not cutting. I'm making a slice. Where I'm making the slice, see, already there is a little 0.5 or 0.6. centimeter of the septum here. You have another point. So it's around 1 centimeter. So I'm making the incision for the anterior dislocation. I'll tell you later. I will do another class. Now you see, Now what you do is elevate this. You elevate this and you elevate it like this and keep a suction here. So your staff should keep a suction here. But the suction should be low power, it should not be high power. The commonest cause of tear in a septal surgery is the powerful suction. So you should not have very powerful suction. Now, what you do is you slice. You should not cut, you should slice around 0.5. And then what you do, you create what is called a septal window. See here, I'm going to the other side. See, I'm going to the other side very clearly. I'm going to the other side. And I'm using, see, many people use a suction elevator. I hate the suction elevator. Why? Because it's very blunt. What I have done, I have taken a freers. I have drilled this area. It is my own custom made. I can cut with this like a knife. And the edge is a little sharp. So the periosteal elevation will be easy. That is how I have created my own freers. Now, I am elevating on both sides just a little bit. And I'm taking off just that cartilage. Why am I taking that cartilage? This is what is called the septal window. So this concept again we published. Why do you want to have a septal window? Why do you want to have that? Now you see, once you remove it, you see what happens. This is the small septal window. Now, what is the advantage of this? The advantage of taking the, see, imagine the scope is kept outside here. If you go inside, the septum is a solid body. And if you put a suction, it will cause Bernoulli and it will fog. So I'm creating more space here for resting the endoscope. So to place the 4 millimeter endoscope, I am removing this part of the septum. So that is why I'm removing and putting a septal window. Now, after making the septal window, what is the next step? Step 6. Elevate on the non-deviated side. Why? Why you want to elevate on the non-deviated side? Because I want, that is the gold. It is gold, like gold. It is like gold. It's like diamond. So you cannot cause a tear on the non-deviated side. If even my residents, anybody create a tear, my heart will stop a beat, believe me. So you cannot create a tear on the non-deviated side. So what I will do is first I will see, I'm trying to elevate slowly. This is the elevation. Now I'm going to the other side. See that? Now I'm using my suction. See how beautifully we're elevating. Both the suction and this elevator. See, this is where the buckle was there. See, that has been elevated by the, and see the movement. Movement is not up, down. It is gentle pushing. See, very, very important. These are all very important, my dear friends. This is very, very important. And once you have elevated that fully, then elevate the side of the deviation and create. So the deviation is like this. Deviation like this, no. So you elevate it, but don't elevate on that edge of that deviation. Don't elevate on the edge of the deviation. Elevate above. You cannot elevate below. You elevate above. Just elevate above and you create an osteotomy. See what I'm doing. See, exactly I'm going to show you this. This is all the secret. This is all secrets of septal correction. See, this is the other side. Now I'm creating an osteotomy. I'm creating a small osteotomy above the deviated side. Above the deviated portion. See, this is the spur, right? I have not elevated here. If I elevate here, it will tear. So this is the non-deviated side. I am just pushing off this non-deviated side. Please, I made an osteotomy above. You see how clearly you can understand this. So we have made an osteotomy. That means this portion is free. This portion is free above. Now, first let me secure. This is the spur. This is spur. This is a dislocated cartilage. This is the bony. That is where it's sitting, the maxilla. So You see that? See, this is the non-deviated side. I'm securing the flap till the floor you elevate. Till the floor you elevate it, because you don't want to tear on this side. It's very, very important. Don't tear this side, my dear friends. If you tear this side, believe me, you are into deep trouble. So first of all, you should secure this flap on the opposite side. So this is the most important part of the septal correction. This is the floor. I've gone till the, see the floor now. I've gone till the floor. Now create an osteotomy. So superiorly I've created an osteotomy. See. Very, very important trick, my dear friends. See, whenever you have a spur, you will have both sometimes a cartilaginous spur, only a bony spur. This cartilage, why it is like this? Because it's dislocated from its center. Yeah, so don't elevate this side. Elevate towards the flap, that is a non-deviated side, over that crust. See, this is cartilage, dislocated cartilage. Between the dislocated cartilage and the bone, you elevate. Between the dislocated cartilage and the bone, you elevate. Gently elevate. Then you have to make an osteotomy below. Very, very important, my dear friends. Why? See, I made an osteotomy here. If I have to make this part loose, then this pivot, this is a pivot here above, this is a pivot here below. So you have to take off both the pivots. So this fragment will become loose. Very simple. This is the secret. This fragment is loose. This fragment becomes loose when you cut above and below. See, very nice. See that? Now you can see the flap. This is the flap, you see. Clearly seen. Now I can elevate this flap. See. See how beautifully we can elevate this. This is the secret, boss. Very, very important point. If you follow this, believe me, you will not have a tear at all. Of course, you might say, why you are struggling so much? No, this is not struggle. This is actually art, a piece of art. Now, after doing like this, see the inferior part, you should not elevate on this acute spur. What you do from anterior, push it towards the opposite side. Now you see how I am, step 10. How you are pushing this, you see. Now I have elevated below. Now see. I am just pushing it towards the opposite side. See. I am not trying to elevate it, my dear friend. I am not trying to elevate it. I am trying to push it towards the opposite. Because upper pivot is gone, lower pivot is gone. There is no fulcrum now. This is loose piece of cartilage. So beautifully, even if it's a super acute spur, I'm sure that, see how I'm pressing. Because this is fully having room. Because I've elevated till the floor, right? So see. I'm now trying to push. And if you see that, that's a super thin part of the mucosa. You'll see the bluish part of the mucosa. Believe me, if you do this, I'm telling you, you'll get goosebumps when you're doing it. So I am telling you, you just push it towards the opposite side. See how the spur is coming out. This is cartilaginous spur, my dear friends. So once I'm doing this, see. It's a super acute spur. And how nicely we are trying to take off that spur. Yes. If I want to get a septum done, I'll do it with Uday Chanukya only, because he is super expert in this. Now see, I have removed the cartilaginous spur. No tear. Now there is a bony spur. Again, I have to make a superior osteotomy, inferior osteotomy, and push this. This is how you have to go about doing the septum. See, there's a bony spur. Don't elevate, my dear friend. See. This is the bony spur. Now, I'm just going there, creating an osteotomy with the freers itself. See, above and below, this is something like a denture. See, I'm pushing it. And just elevating it. Wow, see that coming out. Without a tear, you can beautifully remove it. See the bluish, very thin septum there. Believe me, if you do this, you can take off any hard flap you can take, my dear friends. See that is it. See, even with there's no tear at all. This is the bony spur which has come out. And now you see, examine the spur. Take the spur out. Take the spur out gently. See, that is it. Now you do what is called assessment. This is called step 12, which is the assessment. Now you keep a pack. You keep a pack. Sometimes the mucosa will be a little, rolled up. Even though the bone is not there, the mucosa will be rolled up. Just keep a pack. You can see that. So this is actually, sorry. Now I'm going to show you one more case. Same like this, case 2. In this endoscopic septal correction. And then I will show you, this is actually a pilot. He was a pilot. And there are 2 things a pilot doesn't want. Number 1, he doesn't want nasal obstruction because he might be disqualified. He doesn't want a septal perforation. He'll be definitely disqualified for life. I've closed septal perforation for a lot of pilots. Now, see, again, the same principle. I'm just elevating hydrodissection. And I think I've shown all that. Now I'm making the incision on the skin, of course, on the skin. And then, see, sometimes what happens, my dear friends, is that when you make the incision, you may not make the incision on the mucoperichondrium. See, please understand, if you don't elevate the mucoperichondrium, it will bleed. You should see, it will not be whitish. See, this is the mucoperichondrium. So you should, that is why I don't like this, what is that? The suction elevator. See, I'm using a Cottle here. My dear Cottle, who said hello to us. And we are now, see, that's the mucoperichondrium. The best part is once you elevate the mucoperichondrium, it is bloodless. It is a very avascular field. And you will not tear the flap for sure. And again, here also, I'm just going to do a small septal window. As I told you, this is just a small septal window I'll be doing here. See that? You have to slice, my dear friend. Don't cut. If you cut again, it'll cut through and you will make another incision on the other side. So that too, you should not make it at the level of this incision. Very important, my dear friends. Use a sharp cottles. So this is very important. See, the suction, there is something called Wormald suction elevator. That is very good. You can purchase that. That's with Medtronics. That is good. If I want to recommend, I'll recommend that. So here I'm securing the other side flap. This patient was a pilot, I'm telling you. And he didn't want a tear. He actually asked me, will you tear my septum? I said, no, boss, I will not tear your septum both sides. Hey, don't, don't talk, please.
Don't go.
This is what I don't like, actually. They disturb us. Now, see, my dear friends, I've not edited it. That's why. So it's all, and see, that's a septal window. My endoscope now can go and sit there. And then what you do, you can irrigate. You can ask your assistant to irrigate. See how I'm elevating the opposite side, my dear friends. See my suction. You can keep irrigating and see the movement. Movement is pushing movement. And you have to elevate till the level of the floor. You have to elevate till the level of the floor. Very, very important. All these points are very important. You have to secure this flap. This is like gold platinum. So nicely we have secured. Then I take off this part of the septum. You can see how nicely we can just take off this part of the septum. You can take it piece by piece. You're not doing a rhinoplasty. You don't want a big septum. Now here I'm using this is used as a stent. This suction tip is used as a stent. You know that I'm now taking that deviated part of the cartilage. See, that is called, you just have to dig it out. It's called digging out the septum. So you dig out the septum, that's the cartilaginous part. And then you will see the spur there. I'll just go to the spur. Now you see that I have to make a superior osteotomy, my dear friends. Unless I make a superior osteotomy, it will not become free. And you should not make it at the level of the deviation. Very, very important, my dear friends. See, I'm making the osteotomy with my cottles itself. I'm making an osteotomy so that this spur will become free. So above it will become free. Now, as we make that, now never elevate it. See that I'm making a osteotomy above. And now I have to make an inferior osteotomy now. See, that is all trying to make that. So you have to see, this is the exact acute part of the spur. And you should remember this flap is fully secured. So no question of septal perforation. Very, very important, my dear friends. Never have a septal perforation. If you have a septal perforation, you're done. So I will cut here. I will cut here so that I create a superior osteotomy. And what will I do here for the inferior part? I will do mallet and gooch. And then only I will try to elevate this spur. So this is the trick here involved. This is a trick here involved. You can see I'm making the superior osteotomy. See that? And then how will I do the inferior osteotomy? See that I'm using a mallet and a gooch. Now this is again an elevator, making a superior osteotomy there. Again, I'm going towards the bone. All this is done by pushing movement, not by elevating movement. See now, I'm doing an inferior osteotomy with a mallet and gooch. See that? See how I'm doing. That is very, very important, my dear friends. So once you make the inferior osteotomy, this part is completely free, my dear friends. See that? Now, that is the idea. Totally make this free. Now, once I make it free, what should I do? I should push it towards the opposite side. You try to push it towards the opposite side. See that? So I'm trying to push it towards the opposite side. I'm making that osteotomy. It is actually a very, very important point which I want to convey again and again to my colleagues. Don't ever try to elevate on a side of spur. Very, 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 very important. So once you do that, see the spur has now become free. Now I can remove the spur so easily. That's it, finished. I'm pushing the spur. See that? Now you can see the flap also, inferior flap. Now that's it. So it's so easy, boss. The septal correction is like a piece of art. Again and again I say. Superiorly, many people use lux. Never use lux, my dear friends. You have to cut. You have to cut. You should not use lux. See that now? It's completely straight. There is no. And the turbinate, I'm going to put one separate lecture. So for pilots, what I do, or even for long septums, what I do, I reposition this cartilage inside. So I take that cartilage outside and reposition it, because if it develops a pituitary tumor, then you can easily raise this flap. Again and again, I think about like a skull-based surgeon. Keep a pack, you see, it's completely straight, the septum. So I think I have finished it in half an hour. So that's the end of the septal correction. I hope you enjoyed the technique. It's called a modified endoscopic septoplasty and also septal correction. And this has been published. I'll put it in all the groups so that you can read the article. So I hope you enjoyed it. And if you have any questions now, we are open for questions. So each class is only for half an hour so that you don't get bored. Tomorrow, I'm calling one doctor called Dr. Raghavi. She is a laryngologist, and she's going to give 4 lectures on basics of laryngeal surgery and anatomy, physiology of the larynx and all this. It'll be very interesting from tomorrow. 4 classes I've given Raghavi. She's a youngster. We want to bring young talent in Indian Federation of Otolaryngology. That's our idea. And I requested her and she said, okay, from tomorrow we'll do it. So now if you have any questions regarding septal correction, you can ask me. Wait,
Hello, sir. Sir, how can you prevent the Bernoulli's effect?
So you can prevent the Bernoulli's effect by 2 things. Number 1, you keep a suction as a stent. So you keep a suction as a stent so that there will not be a floppy septum. The suction should not have power. It should be very low power or no power. You can just keep the suction like that. And then you can elevate with the freers. So this is super for preventing Bernoulli. The second thing is you create a septal window. If you create a septal window, you have more space. So the Bernoulli is reduced. The third thing is you ask your assistant to keep irrigating. Even if there is Bernoulli, they can actually irrigate. So this is the 3 techniques used by us Some people use even small gauze pieces to widen that flap. But the problem is you may tear the flap. Be very careful. You may tear the flap. So inferior turbinate, I will demonstrate separately. There are various techniques. I want to tell you simple, straightforward technique. And what is the post-operative follow-up? How many years you are following up? How the turbinate looks. This is what I want to show. Chumma, I don't want to just show some technique and go. This is time tested. So if you have a high, so somebody is asking, how will you have high cartilage deviation? High, let's do like this. So if you have a total bend like this, see, like this, then you have to do a rhinoplasty. Please understand, there's no question of doing just a septal correction. You have to do an external rhinoplasty. If he wants a cosmetic correction, but if he wants a functional correction, there is a trick. How do you do it? So what you do is you can actually cut with the scissors just around 0.5 centimeters. Just so this is a very important point, keystone area. So never create a dip here. He will kill you. So just cut it with a sharp scissors. Okay. Cartilage, what you can do is you can do what is called scoring technique. So make 3 incisions that I have not shown in this video. Maybe in some other class, I will show you how to do scoring technique and then how to do anterior dislocation of septum. All that is a separate class. This is basic. We'll go advanced. So, so if you have any question, you can unmute and ask me. No problem.
Hello,
Hello.
good evening, sir. Dr.
Yeah.
Avijit here.
Tell me.
Yes, sir. I have been following your technique since the last 4 months, sir. And what I usually find is, yes, sir. Thank you, sir. And what I usually find is when I remove the posterior bony part, that is a triradiate part of the bone, sir, I usually get a tear on the deviated side, small tear.
That's a common.
So how to avoid that?
Common
Yes,
problem.
how to avoid that,
Again
sir?
and again. I'm just going to share this. This is the commonest problem, boss. Wait. I am going to show you. This is the commonest problem. And if I see a tear by my resident, you will not believe my BP goes up. You know that? And I also announce prices also. If you do septum without tear, I'll give you price. Like that I announce. Now I'm going to share the screen and show you exactly what is that I'm talking about. Now see here, my dear friends. Now this is what you're asking. Okay, exactly here. Exactly here. Okay. Now, my dear friends, this is cartilaginous deviation. It's dislocated from this bony crest. So first of all, don't elevate here. If you elevate here, 100% you will have a tear. Elevate above. So you elevate above and make 1 incision or cut with the scissors. If you cut it, it's called an osteotomy. You make a superior osteotomy. And then this is attached to a crust, right? Bony crust, right? So take off the bony crust. See, I'm just doing a Manhattan gooch for the bony crust. Wait, I'll show you. First, you secure the other side and then see what I'm doing. So I'm trying to hit it with the Manhattan gooch. Once you hit it with the Manhattan gooch, see what happens? This crust comes out. And then what happens? This is free now. This is free. Okay. Once this is free, you just have to start from anterior. See, that's a flap. Actually, it's a beautifully seen flap. You can, if you follow this technique, you will never create a flap, tear boss. Believe me. It's such a nice, delicate technique. And nowadays, I'm seeing perforations, boss. See, perforation is a criminal offense. That too, anterior perforations. Now, what you do is, you see here, I am now elevating, not elevating, pushing. This is not elevating, this is pushing. See the push. You gently push towards the other side. You will never have a tear. Of course, if you have a super acute deviation, sometimes I also produce a tear, boss. So that's not an issue. But for small acute deviations, I feel that you can easily do without a tear. Some people say if you don't put a tear, you'll have septal hematoma, all that. Boss, there are clips, boss. Nowadays, the coblish with the Nebula has got clips. Just put 2 clips, that's all. You can obliterate that space. But the main, that's an absorbable clip. Now, or you can make a small tear inferiorly. Inferiorly means at this area, so that the Hadad flap is not affected later. If you make a tear here, believe me, that place will definitely tear when you raise the Hadad flap later. Or you're doing a Hadad flap in pituitary surgery. So this is what I want to see, how gently. This is a place where you will tear. This is the commonest place you will tear here, my dear friend. This is the tear. See, you have to push that septum towards the other side. See how it's separating. It's separating. Nicely separating. This is the key. This is the trick. Okay, that's it. So I hope I showed you the trick.
Got it, sir. Got it, sir. Thank you, sir. So what size osteotome are you using for the inferior part? What size osteotome are you using, sir?
Usually I use 3 millimeters, boss.
Okay, sir. Thank you, sir.
3 millimeters, yeah.
Thank you, sir.
Yeah.
Sir,
So
one day we have to show the closure of the septal perforations. You have used many techniques.
boss, see, I am trying one by one,
Yes.
all the slowly I will increase the difficulty level. Septal perforation all comes next, boss. Now we have to show basic septal correction, then anterior dislocation, then superior deviation, all that one class. Half an hour only one class.
Yes,
So
sir.
I will show
Many are requesting for temporoplasty for the beginners. That also will be so.
all that will be shown, boss.
Yes,
Everything will be there.
Yes.
Because the Indian Federation of Otolaryngology, now we are bent on, this is like creating a wave throughout the world.
Yes.
Any other doubts?
Namaste, Dr. Rajan Prasad.
Yes, sir.
Sir, Dr. Rajan.
Yeah, tell me, Dr. Rajendra Prasad Garu.
Sir, any use of martializer or septal crusher for deviation?
All that are gross instruments. Don't use all that. Very nice, fine instruments I've shown you. You have to do it like a piece of art. You cannot use big instrument like this. Don't use all that martializer.
Especially in the endoscopic era.
Yeah. This is all highly refined technique. Highly refined.
No, sir. I am asking you your experience of using martializer or septal crusher in deviation.
Yeah, we can use martializer and then we can martialize the septum and keep, boss. But you can piece, you can cut and put it inside, boss.
Okay. But we use crisscross incisions and keep it. But I want to know whether you have any experience regarding
I have seen it, but I don't use it. I don't need to use it, boss. I just keep it as pieces. Why you want to use my? I have seen it being done. I don't have a martializer anyway. It's just pressing. It will just press.
Yeah.
Some people also use hammer. They hit. All that will not remove spring. You have to either cut the cartilage or make it into pieces.
Sir, you practice the same Royal Pearl technique of septoplasty, endoscopic septoplasty for every age or any age.
What is your question?
See, Royal Pearl technique of endoscopic septoplasty is you can do for any age of the patient.
Yeah. See, pediatric generally I don't do.
Yes,
see, there are grades of deviation, and only if it is causing grade 5, grade 6 only I do. And that too, he is having failure to thrive, and he is just not able to breathe. I generally don't do, but I have done in pediatric 6 years, 7 years. It's not that I have not done, I have done, but I select it very carefully. I have to see the patient again and again. I can't do it in the first time he comes. I cannot do like that. I have to be convinced. Now, pediatric septoplasty is well documented. Many people are recommending that. But in my opinion, I'm still a old timer, I don't want to jump on anything. Small child. So let us wait, see the patient, whether it is failure to thrive not able to breathe at all, grade 6 deviation, impaction, then you do.
Sir, your experience that some people will remove the septum and give a crisscross incision and make it straight and keep inside. That is repositioning of the septum. Your experience.
Yeah, boss, all that I told you, you can do. You can make a, see, you are basically taking all the spring of the cartilage. That's all, by making all these incisions. But see that the spring doesn't return and again the patient doesn't have a deviation. That is the most important thing. Instead of that, cut it into small pieces and keep one by one. That's it. What is the big deal?
Post-op packing, do you
Yeah, basically, see, the best packing I feel is luminized merocell, madam. So you have to pack. If you're not having a tear, you should pack because you might develop a septal hematoma. Or else, if you're scared, you make a small cut in the inferior part of the septum. But I keep luminized merocell for 24 hours and then take it out.
Thank you, sir.
Dr. Janki?
Yeah.
Yeah. When do you prefer to go for your indication regarding the extracorporeal septoplasty, and what is your opinion regarding that?
That's a nice question. Basically, sir, see, I don't do rhinoplasty, sir. Let me tell you honestly. I'm a destroyer. I am not a constructive surgeon.
No, you are a genius, sir.
No. In case they want it, I call one of the rhinoplasty surgeons. I have called right from Bazair sir to Ilambati sir's son. They come to our hospital. We catch 3 or 4 cases. They come and operate. I am not involved in rhinoplasty procedure.
No, sir. Extracorporeal septoplasty.
That is what? No, they do it in rhinoplasty. They do that.
Yeah.
So I don't do that. See, we do Galloway technique. All that I've stopped doing. All these techniques I stopped doing. I just do this modified endoscopic septal correction endoscopic. I don't do anything else.
And another question is, Dr. Janki, that elevating inferior and superior trenier before that septal deviation and then breaking the spur, whether it will protect the tearing of the flap or not.
Whether it will what? What is your question?
Tearing of the septal flap, no? Sometimes.
No. That is why we are doing this technique itself. Create a superior osteotomy, inferior osteotomy. The spur is like this. Gently push it towards the other side. It will beautifully come out with a thin mucosa on the other side. Maybe if it is too much deviated, you might have a small tear. But that also I try to minimize that tear. This is the art. So I don't see, I will not commit defeat by making a cut. Many people make a cut straight away and elevate. I don't that. That is a defeat for me.
Defeat part.
I have to defeat the septum.
Okay, thank you. Thanks a lot.
I hope you're enjoying the class.
Yeah, enjoying. I'm teaching my fellows to in my place. I'm in Gujarat.
I have a question. Dr. Janki?
I
have a question.
Yeah,
Dr. Janki, this is Dr. Dalal, old friend of yours.
Hi, how are you, Dr. Dalal?
I am fine. I'm fine. I would like you to just give a simple trick for anterior caudal dislocation, which is a very common.
I told you I will give a trick. I will show you this in 2 videos. I'm going to show you, but that is the next stage.
Right.
Everything will be there on my YouTube channel, boss. I promise. Anterior, creating an anterior pocket, how to do that, how to tuck in, how to suture, figure of 8, all that I will show.
That's great.
Everything endoscopic. Yes. No headlight, nothing. Everything endoscopic. I'll show how to hold the endoscope and how to make that. All that I'll show. How to hold with a forceps and do a reverse elevation. Please wait. One by one we will show. This is just the start.
Eagerly waiting for all those tricks. Eagerly waiting.
Thank you, Vinit.
Thank you. Thank you very much.
Thank you, Dr. J. Dr. J, I have a question.
Yeah.
Actually, 2 questions. The first question.
Can you identify yourself?
I'm Dr. Tarifi. I'm from Jordan, otolaryngologist from Jordan.
Wow. Jordan person is saying, yeah, very good. World is small, boss. World is very
Yes.
small. Yeah.
Yeah, it is small. Yeah. Thank you for nice presentations, actually. I have two questions. When do you consider internal splints post-operatively after septoplasty?
Splint? You mean splint?
Yes. Yes.
I don't do splints. Why I
Just
should do
Merocel.
splint? Humanize Merocel. Best. He'll breathe. At the same time, you make that flap unite with each other. That's it. You put
Okay.
it 24 hours, it's going to unite. Why you want splint?
Okay.
Of course.
The other question.
See, there
The
are
other
various techniques. I'm not telling it's wrong. If you're happy with it, do it. It's not that there's only one technique. This is my technique.
Yes. The other question is, do you have any tricks in elevating mucoperiosteum from the maxillary crest when it is deviated? You know, it's very adherent and it's not continuous with the perichondrium of the cartilage. I mean, the mucosa is continuous, but the mucoperichondrium is not continuous with the mucoperiosteum. Correct?
My dear friend, then that means you have not understood this technique at all. See, I'm sharing this. See here. See this. See, my dear friend. Okay. Now, this is the spur, right? This is the cartilaginous spur. This is the bony spur, right? Hello.
Correct. Yes.
So at this region, this is the mucoperichondrium, right? Correct or
Right.
wrong? Okay. And at this level, what will be there? This is
Periosteum.
Correct. This is the mucoperiosteum. So what I am doing is, before you separate the mucoperiosteum, you have to take off this bone. See, I'm taking off completely. And then what I do is I make this, see what I'm doing. I'm chiseling it off.
Ah, I see.
You see what I'm doing? I'm chiseling it off so that I expose this area. See that? Now the mucoperiosteum will be exposed. See, slowly I'll show you. See, once I do this, what will happen? See what happens. Not playing.
Yeah.
No problem. Just see, once I remove it, I go to the next frame. Now this is the mucoperiosteum. Now I will elevate this. This is the bone. Come out. Now I am going to elevate it. See that? This is clearly seen. And then I will start elevating now. See. Now see clearly. Then the cartilage. See, first you make the osteotomy, my dear friend, on the cartilage. Then you chisel the bone, my dear friend. And then only you should remove that acute part. This is the trick. This is the main trick of the surgery.
Okay, I see. But I like the way that you are pushing the spur so that you are just handling it superiorly and inferiorly, and then push it rather than elevating the mucosa.
Yes, don't elevate.
Yeah,
If
that's
you
nice.
elevate, you will tap.
Yeah, sure.
Okay, very, very important, my dear friend. That the whole trick is don't elevate. Push. This is the most important thing. Okay.
Thank you so much.
Thank you. So, anybody else wants to ask any question?
No, sir. Good night.
So, good night, everyone.
Good night, sir. Sir, thank you, sir.
So,
Thank you.
tomorrow, my dear friend, on behalf of Indian Federation of Otolaryngology, Dr. Raghavi, youngster, is going to talk. Beautiful speaker she is. And you learn step by step of laryngology and deglutology. Swallowing tricks, everything. So every day there will be something at 8:30 Indian Standard Time. Thank you. God bless you and bye-bye.
Thank you, sir. Thank you, sir.
This all
Namaste.
will be available on YouTube, Royal Pearl ENT University channel.